All right, let's jump right in. Today, we're taking a closer look at a pathogen that, for every medical microbiologist, is a constant and important challenge: Bordetella pertussis, the little troublemaker behind whooping cough. So here's the thing that's so wild about pertussis. We have effective vaccines, right? Yet, this disease is making a major comeback all over the world. A big part of the reason is the shift we made from the old whole cell vaccines to the much safer acellular ones. The trade-off seems to be that the immunity from these newer vaccines might fade a bit faster. This means we're seeing outbreaks again, even in places with high vaccination rates, making this a really tricky, moving target for public health. And the stakes here are just incredibly high. The ones who are most at risk, the ones who suffer the most severe complications and even death, are infants under a year old. For these tiny patients, this is so much more than a bad cough. It can be a devastating, life-threatening illness. And that, of course, puts immense pressure on us in the lab to get the diagnosis right and get it right fast. Now, to really appreciate what we're doing on the bench, we need to understand what's happening at the bedside. So let's quickly walk through the clinical journey of pertussis. It's a bit of a drama that unfolds in 3 classic stages. It all starts with what's called the catarrhal stage. Honestly, it just looks like a common cold. Runny nose, maybe a mild cough. But here's the catch. This is when the patient is most infectious, spreading the bacteria everywhere. Then the main event kicks in, the paroxysmal stage. This is what everyone thinks of with whooping cough, those violent, intense coughing fits that leave a person gasping for air, often with that signature whoop sound. And finally, if they get through that, there's the long, slow, convalescent stage, where the cough gradually gets better, but it can drag on for weeks, even months. This progression is why we have to be so vigilant, especially with infants. You see, in babies, you might not even hear that classic whoop. Their primary symptom could just be apnea. They just stop breathing. It's absolutely terrifying. On top of that, pneumonia is the most common reason pertussis is fatal in this age group. And there's also the very real risk of seizures, brain damage, and severe lung complications. Okay, let's bring it back to our world. Time to move from the bedside to the bench. Identifying Bordetella pertussis in the lab is, well, it's a real lesson in dealing with a finicky, incredibly picky pathogen. So if you're looking down the microscope, its appearance is pretty subtle. You're looking for these tiny, faintly staining gram-negative coccobacilli. They're often found just hanging out by themselves, or in these small, loose little clumps. It doesn't scream at you, so you've really got to have a trained eye. Now, for any labs out there that are still doing culture for this bug, you know the struggle. This organism is demanding. It's a strict aerobe, it needs humidity, and it gets inhibited by things in our standard lab media. That's why you have to use the special stuff, like Regan-Lowe or the classic Bordetella agar. And even with all that, you have to play the waiting game. It can take up to 12 days for those tiny, domed, glistening colonies that look like little drops of mercury to finally show up. So if you do manage to get it to grow, you can use these key biochemicals to tell it apart from its close relatives, like Bordetella pertussis and Bordetella bronchoseptica. But let's be honest, in today's world, molecular diagnostics are king. Real-time PCR is now the standard pretty much everywhere because it's just so much faster and more sensitive. Most assays go after the insertion sequence IS481. Why? Because there are tons of copies in the Bordetella pertussis genome, which makes for a super sensitive test. But, and this is a huge but for the lab, IS481 is also found in Bordetella homesi, which can really muddy the waters and cause some diagnostic headaches.
Okay, so let's say you've got a rapid molecular diagnosis. Great! But now we hit one of the biggest hurdles we face as microbiologists. How do we actually guide the treatment? This is where we run into a major gap in our usual lab workflow. Trying to perform antimicrobial susceptibility testing, or AST, on Bordetella pertussis is a nightmare. It grows so slowly that our standard methods just don't work well. And here's a massive pitfall you have to know about. You can't use your primary culture media like Regan-Lowe for susceptibility testing. You just can't. The charcoal in that agar actually soaks up the antibiotics, which can give you a falsely high result and make you think you're dealing with a resistant bug when you're not.
Which brings us to the million-dollar question for every clinical microbiologist. Let's say we actually manage to get an MIC value. What do we do with it? How on earth do we give clinicians meaningful advice when we don't have any official clinical breakpoints to guide us? And that, right there, is the reality we live in. As of 2025, EUCAST has no clinical breakpoints for Bordetella pertussis. There just isn't enough solid clinical data out there to link an MIC value to whether a patient will actually get better.
So what does that mean for us? It means we can't report a simple susceptible or resistant. We have to fall back on what the clinical guidelines recommend for treatment.
So, what do those guidelines tell us to do? Well, if we look at the Dutch SWAB and LCI recommendations here, you see a really clear pattern. It's all about the macrolides. For adults and most kids, it's a nice, short 3-day course of azithromycin. For the very youngest infants, those under 4 weeks old, the recommendation shifts over to clarithromycin for 5 days.
And this lines up really well with international guidelines, like these ones from the CDC in the United States. Again, you see azithromycin is the top choice across the board. The CDC gives slightly different dosing regimens, and they also list a few alternatives like clarithromycin, erythromycin, and for older patients, trimethoprim sulfamethoxazole. The take-home message is clear, though. The global consensus points straight to macrolides. Now, when you're treating kids, you have to be extra careful. Any infant under about 3 to 6 months old with suspected pertussis needs to be considered for hospitalization, period. Azithromycin is strongly preferred for newborns because another macrolide, erythromycin, has been linked to a nasty condition called infantile hypertrophic pyloric stenosis. And one more crucial point, trimethoprim sulfamethoxazole is an absolute no-go for infants under 2 months of age.
Okay, last but definitely not least, let's talk about stopping this bug in its tracks. Because treatment can be so complicated and the disease so severe, infection prevention and control is everything. For any patient who is hospitalized with either suspected or confirmed pertussis, the rule is droplet precautions. This is non-negotiable. It means they need to be in a single room, and anyone who goes in that room needs to be wearing a surgical mask. We have to stop those respiratory droplets from spreading. The bigger picture strategy really boils down to 3 key things. First, isolation. The patient is generally considered non-infectious after 5 full days of the right antibiotic, and then you can stop the extra precautions. Second, post-exposure prophylaxis, or PEP. This means giving antibiotics to high-risk close contacts, like family members, to prevent them from getting sick. And third, the absolute cornerstone of all prevention, vaccination. And there's a huge emphasis now on making sure pregnant women get vaccinated to pass on that protection to their newborns from day 1. Just so you know, all of the information that we've gone through in this explainer was put together using a Gemini deep search. If you want to dive deeper and see a full list of all the sources and references we used, please check out the notebook document that goes along with this. You know, we really want these explainers to be as practical and useful as possible for all of you working on the front lines. Your real-world experience from the clinic and the lab is just so valuable in helping us make this content better. So if you found this helpful, please subscribe to the channel and definitely leave your thoughts and experiences in the comments below. We'd really love to hear from you. Here's a question. What are the biggest challenges your lab is facing with Pertussis diagnostics right now? For example, how are you dealing with those tricky IS481 positive results that might actually be Bordetella home C? Let's get a conversation started. Thanks so much for watching.